Now, for our Hodgkin's versus non-Hodgkin's lymphomas, we talk about a Hodgkin lymphoma. It may present similar to infection, like with fever, okay? The spread is going to be contiguous to adjacent lymph nodes, which means that it kind of goes in order, like starting in the mediastinum or thorax and kind of spreads down in order, as opposed to your non-Hodgkin lymphoma. It can kind of bounce around and jump around in different organs and lymph nodes in the body, okay? Our classification is based on the inflammatory response and not the malignant cell, when it's Hodgkin lymphoma. There's no leukemic state for Hodgkin lymphoma, okay? And extranodal spread is uncommon. Now, the bad guy in all this, the malignant cell, is called the Reed-Sternberg cell. They're intermixed with reactive inflammatory cells, okay? So they're the bad guy. We see here, the CD markers are going to be CD15 and 30. So we know it's a B cell. For a long time, we didn't know what the origin of the cell was, but now we know it is a B cell. However, note that with the lymphocyte predominant type of Hodgkin lymphoma, that the B cell markers will be negative for 15 and 30. Here's a biopsy of the Reed-Sternberg cell that you can see here. Now, typically we describe the cell as having the owl's eye appearance, so two owl's eye, because you have the little halo around the nucleolus, okay, compared to our normal lymphocyte. For differentiation on the exam, if you see or they describe a single owl's eye, it is what? It is CMV. So two owl's eye, Reed-Sternberg cell, one owl's eye is CMV. Here's a biopsy of Reed-Sternberg cell, lower magnification. The right dead center is our bilobed nucleus with the owl's eye appearance that you will see. You see other inflammatory cells like lymphocytes, plasma cells, etc. Now, the different types, we have the so-called lymphocyte-rich type. Now, this one is rare, and the key with this one is associated with reactive lymphocytes and associated with Epstein-Barr virus, okay? Now, the lymphocyte predominant type, the key with this one is you're going to have a good prognosis. Why? Because the name is telling you you're going to have a lot of lymphocytes, but very few Reed-Sternberg cells. Because again, the Reed-Sternberg cell is the bad guy. You can have a variant of the Reed-Sternberg cell called popcorn cell. Why is that? Because the nucleus looks like a popcorn kernel. Now, I don't know if it's over Rettenbauer or it's going to be Pop Secret or Act 2 kind of popcorn shell, whatever. But like I said before, negative for CD15 and 30. With the mixed cellularity type, you're going to have eosinophils and plasma cells and other types of inflammatory cells associated with your Reed-Sternberg cell and associated with our IL-5 secretion. Now, with the lymphocyte depleted type, this one going to have few lymphocytes and many Reed-Sternberg cells, so it's going to have the worst prognosis. However, the most common type is going to be our nodular sclerosis type. So now we're talking about nodules, inflammatory cells with Reed-Sternberg cells separated by scar tissue, okay? That's also the most common type seen in females, okay? The Reed-Sternberg cell variant is called the lacunar cell. Why? The cell is going to be large with clear cytoplasm with a nucleus in the center. So it looks like a chondrocyte or an osteocyte in the lacuna of cartilage or bone, okay? We have a bimodal age group, late 20s and over 50s. Typical patient, though, is going to be our young male with this. Again, you're going to have painless enlargement of the lymph nodes. The patient will present with fever, weight loss, and night sweats. So on the exam, if a young male presents with fever, weight loss, and night sweats, your differential is going to be Hodgkin lymphoma, AIDS, or TB. So be aware of that, okay? The prognosis is poor, and it's directly proportional to the amount of Reed-Sternberg cells. Again, they're the bad guys, so the more you have, the worse the prognosis, okay? Now, it's important that these patients need chemotherapy and radiation therapy for treatment. In fact, we have 4 stages, typically stage 1 and 2, above the diaphragm. You're going to treat it with radiation. 3 and 4 is below the diaphragm. You typically treat it with chemotherapy. And the key thing to look for to separate 2 and 3, because that's going to be very important for our therapy, is the spleen. If the spleen's involved, then more likely you at least got stage 3, because again, it's above and below the diaphragm, so the patient needs chemotherapy. Also, too, a complication of the therapy is what? You may give the person a cancer.